All right, so welcome to Morning Report. This is a case from a little while back that Catherine actually left for me. And so it's an interesting one and certainly related to the fact that we're going into the winter when respiratory season is uh, full in glory. So stridulous and feverish. So we have an 11-year-old male with shortness of breath and fever, and he presented to the main med emergency department. What more would you want to know?
The kid immunized?
Yes, fully immunized.
How long ago did it start?
So let's see. So about 2 to 3 days ago, he started having cough, sore throat, congestion, and 2 days ago he had fever, and that's the only documented fever that he had. So yeah, 2 to 3 days ago.
Any sick contacts?
No known sick contacts. He does go to school though.
And what season are we in?
This is February, so winter.
Pre-COVID.
Well, technically, I guess before COVID really kind of exploded, but COVID was certainly, spreading it.
He has medical history?
Yes. So he has a history of some reactive airway disease when he was younger. He's not treated with any medications at this point. He also has a history of oropharyngeal dysphagia of unknown kind of origin. He had an EGD done in 2019 for which he was actually admitted after because he had this kind of strange sepsis-like picture for which no organism was ever specified. They don't really see, unsure of like the relation of the EGD and the sepsis type picture, but and then there was one other thing I can't remember off the top of my head, but we'll get there. Those are the primary things. He did have his tonsils out when he was a little bit younger because he had some strep infections as well. Look in the chat. What changed today that brought them in? That's a really good question. So he woke up. Today's a Tuesday, so symptoms started on a Saturday. Today's Tuesday. He woke up with acute shortness of breath and feeling like he couldn't breathe, and he was very anxious about it. And his parents thought that they heard a high-pitched breathing sound that was abnormal.
Carolyn, is he developmentally normal or delayed?
Yes, developmentally normal. Mm-hmm.
Have they noticed any change to the sound of his voice over the last day?
Yes, over the last day, or since this morning, much more hoarse in his voice, yeah.
Any drooling?
What was that?
Any drooling?
Drooling, no drooling.
Can he swallow okay?
Yeah, he's swallowing all right.
Can he describe where he's feeling the shortness of breath? Like, is it down in his chest or is he feeling it up in his throat?
He really feels it kind of in his throat, and he says that his throat hurts. But I don't know that he doesn't really describe. He can't quite describe where the shortness of breath is coming from, but he just complains about his throat.
Does he remember swallowing anything and getting stuck in his throat, or having like a cough or choking episode recently?
No, those are all great questions, though.
Any like crunchy foods or spiky foods like chips?
No. Nothing out of the ordinary. Maybe he ate some chips, but nothing that seemed out of the ordinary.
Is this cough productive?
No.
Carolyn, is he able to pinpoint when he's having difficulty breathing? Is it on inhalation? Is it on exhalation? Is it both?
He can't really pinpoint. He's just very anxious about breathing.
In his past medical history, was there anything around his birth? Like, did he ever require intubation in the NICU or anything like that?
That's also a good question. No history of intubation. And his birth was non-contributory. Yeah. Cool. Good job. Lots of great questions. We will go back. Okay. So kind of going through everything we just went through. So sort of 4 days of cough, congestion, rhinorrhea, really just the last 24 hours, well, within the last 24 hours, developed the difficulty breathing. And parents thought they heard stridor at home, so the high-pitched breathing sound. His voice is hoarse and kind of muffled. He didn't really want to lie flat. He just wanted to be sitting upright. Not tripoding though, not like leaning forward. He just wanted to be upright. Definitely anxious about breathing or how he was breathing. He did have some vomiting with the cough and with the shortness of breath. No drooling, able to swallow. He had the fever on Sunday, but otherwise has been afebrile. He actually, so Sunday was the fever. He did not go to school on Monday, but was able to go to school on Tuesday because he was fever-free. And then developed kind of the acute worsening of his symptoms. So we talked about the oropharyngeal dysphagia, which unclear sort of the etiology of that. He had the tonsillectomy. Sepsis was related to the oropharyngeal dysphagia, and he had an elevated lactate, but as I said, there was no organism ever identified. And then the reactive airway disease kind of as a younger child, for which he's not treated anymore. No medications or allergies.
Hey, Carolyn,
Yeah,
can you go back?
yeah.
What do you mean by the sepsis was related to the oropharyngeal dysphagia?
So he had an EGD to kind of delineate why he had oropharyngeal dysphagia, and there was nothing abnormal about his EGD. And after his EGD, he developed a sepsis-like picture. It was sort of unclear kind of what happened because there was never any organism, so they didn't recover an organism from his oropharynx or his airway in his blood. So really unsure of why he developed those symptoms after the EGD.
Okay, thanks.
Yeah, of course.
And Carolyn, at his baseline, is there any choking, gagging? I know there wasn't a clear aspiration event leading to this, but at his baseline, like what led to the diagnosis of oropharyngeal dysphagia? Do you know that?
So I didn't really look back into his past about that. It was not noted in the history and physical that he was having issues with eating, and certainly didn't have any issues. I didn't put his weight in here, but he clearly eats because he's not underweight. So I didn't look back into that, to be honest. Okay, so when you see this kid, blood pressure 101/57, heart rate of 139, he is afebrile, respiratory rate of 20, and he's satting 95% on room air. So he is kind of anxious appearing, but doesn't appear to be in like acute distress. TMs are clear. Pupils were equal round, reactive to light bilaterally. His oropharynx is mildly edematous, but not erythematous, and there's no exudate, and his uvula is midline. He does have some kind of shoddy cervical lymphadenopathy, nothing that's like really prominent. He was tachycardic. He has no respiratory distress when he's in front of you and no retractions, and he doesn't currently have any stridor and no wheeze, but he only will sit upright. He does not want to lay down for you, and he's doing okay with his secretions. Everything else looked all right. He's a pale kid, but other than that, looked fine. So what workup would you want to do?
I'm gonna get a chest X-ray and get the airway in it, and then want to get some initial labs. So CMP, CBC with a differential.
Perfect. Good. You nailed it right on the head. So even though he had a tonsillectomy, it doesn't necessarily mean that he can't have a strep throat infection. Oftentimes, well, sometimes at least, you can have remnants of the tonsils left behind, or the tonsil can actually kind of grow back and you can have infection. So he had a rapid strep test that was negative. He did have a CBC with a diff, and his white count was normal at 6.4 and 69% neutrophils, and his other counts were normal as well. And he had a CMP, which was totally normal. He had an X-ray of the soft tissue of his neck. They didn't actually do a chest X-ray, a full chest X-ray, just the neck, which did show subtle tapering of the upper trachea. The soft tissue, there was soft tissue thickening at the base of the tongue. And so it was difficult to kind of delineate where the epiglottis was in the X-ray, but the retropharyngeal space did not look widened. But definitely abnormal with this sort of tapering of the upper trachea. So consults were put in for peds and ENT to come and see him. So what sort of things are you thinking about when it comes to stridor? What would be on your differential diagnosis for this kid? Even though he's not exhibiting stridor right now, but you have that X-ray finding that makes you think maybe he did have some stridor.
Could be an RPA, epiglottitis, although with his being fully immunized and that X-ray less likely.
Angioedema.
Yep.
Plain old croup.
Yep. Plain old croup.
A VCD, vocal cord dysfunction.
Yeah, definitely all good things. So I think all of these things were kind of alluded to in your questions. So I definitely know that you're thinking of all of these things. So croup, foreign body. So did he aspirate something? Obviously, you didn't have anything radio opaque or obvious on the X-ray, but that doesn't mean that there couldn't be like a little plastic dinosaur down there in his airway or something. Strep infection or EBV, something that's causing some edema of his upper airway, epiglottitis, bacterial tracheitis, the RPA, and then he did have an EGD, but hasn't had a bronchoscopy before, so laryngomalacia or tracheomalacia. Although Annie can correct me if I'm wrong, if he had these things, he would have probably had symptoms before the age of 11 years old. Because his airway has grown a lot with him already, and generally with some of these things, as the airway grows, the symptoms improve. But on the differential, a vascular ring also would be a little less likely to make it to 11 years old without manifesting itself. And then subglottic stenosis, which generally would not necessarily happen just organically, would happen like if he had been intubated in the past and had trauma to the area, and then had some stenosis following that. And this is just a representation of stridor with kind of the up-down sort of intensity of stridor. I think everybody's probably heard stridor before, but we can go back to that at the end if we have time.
I think, Carolyn, one thing that's important is that a lot of things get called stridor or wheezing that aren't. And so it's really helpful if you can demonstrate stridor to the family, because it certainly changes your differential, right? And even more challenging is to try and pinpoint when the stridor may occur, but that absolutely changes your differential diagnosis and can help localize where the noise may be. But I otherwise think it's a great differential.
Yeah, thank you. All right, so evaluation and plan for this kid. So with the x-ray findings, there was concern for possible bacterial component. And so he got a dose of Unison in the ED, a dose of dexamethasone to decrease some of the inflammation, or hopefully decrease some of the inflammation, and ENT was consulted. And they ended up doing a flexible laryngoscopy at the bedside. And his epiglottis was normal in appearance. The vocal cords were functioning normally, but the subglottis was narrowed with erythema and exudate, concerning for bacterial tracheitis. So they recommended IV antibiotics and IV steroids for 24 hours, then a short PO taper for him. So he was admitted for 24 hours, maybe a little over 24 hours, and had pretty significant improvement. Not that he was overly symptomatic in the ED, but his overall anxiety definitely went down. He did not have any stridor, and his throat began to feel better. So all good things. And he was discharged to finish 10 days of antibiotics. He was treated with Augmentin and then a 4-day course, I think, of PO dexamethasone with some ENT follow-up. And there was a question at discharge about whether or not he needed to have an immune sort of workup, just because it's kind of rare out of the blue for an 11-year-old, otherwise healthy seeming male to have bacterial tracheitis. It's just not super common. And he had a history of what they thought was a vaccine strain, strep pneumonia, and so there was this question about an immune workup, but it was not something that was going to be done in the hospital, and it's not something that I've seen documented being done yet, and he's otherwise been healthy. So he had ENT follow-up. Sorry, this is a little bit blurry, but he had ENT follow-up a couple of weeks later, and they scoped him again, and they didn't have an initial picture, which would have been really cool, of his airway. But this is shows resolution of the erythema and exudate and significant improvement in this upper airway following antibiotic therapy. Oh, here's my daily dose of Archie. So in the last couple minutes, we're going to talk about bacterial tracheitis and talk about stridor a little bit. So what is stridor? So it's a high-pitched breathing sound, generally heard best over the anterior neck. And where you hear it best depends on where it's coming from. So whether it's extrathoracic or intrathoracic, which this line delineates extrathoracic versus intrathoracic. And it's actually a vibratory sound, so an oscillation of a narrowed large airway. And you can describe it based on the respiratory phase that you hear it. So inspiratory is most common and most commonly comes from an extrathoracic source or extrathoracic location. But you can also have expiratory stridor or biphasic stridor. And kind of as I mentioned, the differential diagnosis depends on the location and then also on the phase of the respiratory cycle that you're hearing it. This was just like this is a really great schematic, I think, that breaks it down into locations. So intrathoracic area, so generally you'll hear an expiratory stridor and or a wheezing sort of sound, and this is generally infection, foreign body, anaphylaxis, congenital source, so the bronchial tree, tracheobronchial tree malformation. This is where a vascular sling or ring would come into play, or a tumor. And then you move up the airway, glottic and subglottic, and then supraglottic, which is generally where you're going to hear the inspiratory stridor. So anaphylaxis, epiglottitis, this is RPA and laryngomalacia. And you can also have sort of the upper airway tumors, kind of uncommon, but and then glottic and subglottic is where croup comes in. Also anaphylaxis, a foreign body can be stuck there. Bacterial tracheitis, tracheomalacia, subglottic stenosis from trauma, and then vocal cord paralysis or dysfunction. So bacterial tracheitis is an invasive exudative infection of the soft tissues of the trachea, but it can also extend up from your trachea, so up into your pharynx or larynx, or down into your bronchi. So it can get anywhere. So laryngotracheobronchitis is kind of what UpToDate said was a better name for it, but I think it's just like really a mouthful of a name, so we'll keep bacterial tracheitis. And generally it's upper respiratory tract pathogens, because your airway is colonized soon after birth, and those are things that are meant to be there and should be there, but can become invasive when it comes to infections. Bacterial tracheitis overall is pretty rare and generally occurs, if it does, in kids less than 6 years of age. And things that you want to think about when it comes to bacterial tracheitis is whether or not they've had a preceding viral illness. So sometimes if they're not managing their secretions as well as they could be, and have had symptoms for a few days, or if they've had like a viral sinusitis and pooling sort of secretions, they're at a little bit increased risk of a superseding bacterial infection. Artificial airways, so kids who are intubated, kids who have tracheostomies obviously are at an increased risk, especially because they do spend a lot of time in the hospital, and hospital-borne infections happen when you have a direct sort of path into the airway. And it can be an airway emergency. So if you have all of this edema and inflammation and exudate or pus, frank pus in the airway can kind of close off and become pretty small pretty quick, leading to the need to acutely manage that airway. Luckily not for our kid. So pathogens and presentations. So again, we're thinking of our common upper respiratory pathogens. So Staph aureus is the most common. It can be caused by MRSA, but kind of similarly to other MRSA infections, those kids are going to look pretty sick. Strep pneumoniae, group A strep, Moraxella, and Haemophilus. So most commonly, you have a prodrome of respiratory symptoms, and then more severe sort of symptoms develop a few days in, so like 2 to 3 days in. Kids who have had a few days of symptoms then develop respiratory distress or trouble breathing. Less commonly, you have kind of a less than 24-hour onset where you have no prodrome and you just kind of develop these symptoms. Symptoms include fever, stridor, it can be inspiratory or biphasic, generally cough, respiratory distress. Drooling is a little less common, more common with epiglottitis. Odynophagia or dysphagia, inability to swallow, and then the changes in the voice, hoarseness, or sort of a muffled sound. So diagnosis and management. So imaging is important in a lot of cases. You can see the steeple sign, which is kind of pathognomonic for croup, but you're looking for that subglottic narrowing. And then your best diagnostic tool is looking at the airway. So getting ENT in to do a scope to look at that airway and directly visualize what's going on. But if that child isn't stable, obviously your ABCs are going to come first in stabilizing them. If a kid has an artificial airway and you can get a tracheal aspirate, that's often really helpful. Then you can direct your management at the bugs that you grow. Also really important for kids who have a tracheostomy that you get tracheal aspirates, because then you can kind of follow what bugs they grow over time. And then labs. Again, labs are going to be dictated by how sick they look. Do they need a blood culture? they're hypotensive and looking sort of septic, they do need a blood culture, but sepsis is not a common picture alongside bacterial tracheitis. But still, it's a case dependent sort of workup. Management, again, as I said, airway, breathing, circulation, racemic epi. Generally, if you're thinking it could be croup and they look kind of punky to begin with, you can try racemic epi and see if it helps. But other nebulized medications are generally not helpful. So things like albuterol, not helpful. Hypertonic saline, not helpful. Corticosteroids are not routinely used, but generally, again, if you're thinking down the croup sort of line, you're going to give them a dose of dexamethasone anyway, just to see if it helps. And then if it does help, it does seem to help, you can continue steroids for those kids. And then antibiotics, you want to think about whether or not you need MRSA coverage, if they have a history of MRSA, if they've grown MRSA before from a tracheal aspirate, again, if they have a tracheostomy or an artificial airway. And if they look really sick, you can start with MRSA coverage and then wean that off. But generally, you just want some good gram-positive coverage. So something like Unison, which our kid got, and then you can switch to an oral Amox or Augmentin. And that's all I've got. Are there any questions, comments? Kind of a cool case.
It's kind of unusual because usually when I've seen bacterial tracheitis, they look more toxic and they are pretty febrile. And this kid didn't have those things. So that was a little surprising.
Yeah.
Yeah, also his age.
Did they isolate a pathogen for him?
No, they didn't take a tracheal aspirate.
Weird.
Unfortunately, yeah.
Are these kids generally, if they do need an advanced airway, is this like an anesthesia airway that we're talking about? How hard are they to do?
That's a good question. Annie, do you have any thoughts on that?
Yeah, this is definitely when you'd want PD, ENT, and anesthesia consulted on if there's any concern for respiratory distress or even just a heads up. But Carolyn, what a really interesting case, and it sounds like he hasn't been fully captured yet, although the follow-up you have demonstrates improvement. But I between the age and the relative, healthy history regarding infections, but then this kind of uncaptured history of oropharyngeal dysphagia, he's definitely one where I think thinking about aerodigestive clinic and the immune workup is a good idea to fully kind of understand why this happened at 11.
Yeah, definitely. I agree.
This is Chris Modal. To add to Pam's comments, so I agree these kids typically come in with fever, looking more ill and toxic appearing. But the other thing is important to think about patients that are presenting again with croup that has kind of been prolonged and not maybe responded to the initial kind of therapy. So it might be a kid that's come back to the emergency room after visiting previously and gotten dexamethasone. So a lot of times these kids are, they have the viral inflammation and infection of the larynx, and then it, presents the opportunity for bacteria to get in there and cause the infection. So it's kind of that croup that's not following the typical course of croup. So there's other things to think about in those kiddos too, in terms of your differential, but definitely thinking about bacterial tracheitis in a kid who's febrile and ill appearing with kind of that prolonged croup history, it's a good thing to think about.
Yeah, thank you. All right, thank you everybody for participating. Hopefully everybody has a great Monday, and let me know if you need anything.